Hi, and welcome to Detours, Understanding Acquired Brain Injury. I want to talk to you about a branch of, a branch of psychology and medicine kind of together, and that is neuropsychology. Now, there are two branches within neuropsychology. There is cognitive neuropsychology and clinical neuropsychology. Now, most of you have heard of clinical neuropsychology because they test people with brain injury. But cognitive neuropsychology is the branch that tests the normies, the neurotypicals, to understand more about how the brain works. They're the ones who come up with a lot of the tests in the first place, although clinical neuropsychologists do come up with tests. But the first tests and things like that, oftentimes, many of those are much of the initial research and things like that is done by cognitive neuropsychologists who want to understand more about cognition and understanding things like that. It is cognitive neuropsychology is a newer branch of neuropsychology. Clinical's older. A lot of the initial work from clinical neuropsychology is based on physiological psychology, which studies the body and responses and comes out of early psychiatry. And if you look at these studies, the anatomical work, things like that, that goes back to the days of Freud and Jung and those who are trying to understand the mind as a physical system. A lot of the work done in those early days was with, for example, stroke patients and people who did have head injuries and who died. And then they would do an autopsy and look at the brain and do what are called lesion studies. They would say, oh, well, there's damage to this area and we saw these behaviors. It must be from damage to these areas that causes these changes in the brain. And there were different anatomists where anatomy was clearly not defined because there are a lot of limitations on what the church allowed, the Catholic Church and the early Protestant churches allowed when it came to dissecting the human body. And so only in the late 19th century did we really start to be able to understand how the brain is laid out and how it's structured. Some of the work done by Broca, if you're familiar with Broca's aphasia, he had a patient that he named Ton because he could only say the word Ton. He understood language, but he could only say certain words. And so Broca's aphasia was named after Broca, and it dealt more with the motor skills and motor programming and damage more into the frontal lobe in the left frontal area. And yeah, I know everything's backwards on the camera, but damage to the frontal cortex in Broca's area, what's called Broca's area, because he was the anatomist who labeled a lot of area. Then Wernicke came along and he did work on sensory aphasia, where a person, or fluent aphasia, where a person can speak and say many different words, but doesn't understand. And so he did work and discovered the area, another patient who had trouble with fluent aphasia. They could say the different words and pronounce them fine, but did not understand. And he realized that there's a connection between, damage to the dictionary, more or less, in the brain, which has associated words connected to it, and then the inability to pronounce and speak the words. Again, that came a little later in the 1870s, and it was also coupled with the art of phrenology, which was a pseudoscience, but they believed that they could feel the bumps on your head and tell your intelligence or other skills. Obviously, it's complete nonsense, but for a long time, there were these people who had these phrenology models of the head and like different areas being associated with different ideas. And so that was popular too. A number of kings of England had their heads analyzed for certain strengths and weaknesses and like what they were good at and what they couldn't do. But eventually, in the beginning of the 20th century came the first attempts at measuring intelligence using standardized tests, which is where you give a series of assessments to a large number of people, a very large number. And with universities, public universities becoming more common, it was possible to test thousands and thousands of people and see how the majority do. And that led to the development of the bell curve that could then be used for comparison to those who did not perform like other people. And so you could look and say, well, gee, these areas of the tests suggest that this person may have a particular problem with this specific skill. And it's from this that we see neuropsychology emerging in the early 1900s, 19-teens. Wilhelm Wundt and a couple other well-known names back then who figured out that these kind of tests could reveal brain damage, and they put it together with the work of like Broca and Wernicke and those other people, and they said, okay, so damage to certain areas of the brain will affect behavior, language, cognition, memory, understanding, and that led to the birth of modern neuropsychology. Now, a lot of people have asked, well, hey, wait a minute, why do they test everybody in the same quiet office kind of environment? The reason is simple. If you're going to give somebody a test, it has to be in the same conditions in which the original tests, contemporary, yes, are given. So if I'm going to administer a test and I want to make sure that it's valid, that is, that it is testing the thing I want to test and it is reliable, that it will produce the same kind of results, I have to reproduce the original conditions in which the large group was tested in as much as possible. I have to replicate as many of the same conditions as possible. So they give the people, the normies that they test, the neurotypicals, are mostly tested in universities or in doctors' offices, hospitals and stuff. They'll recruit and pay, tens of thousands, hundreds of thousands of people to take these tests who have no disabilities, no problems. And they'll test them in a quiet, non-distracting environment because you don't want, screaming babies and all kinds of yelling, or you don't want an office environment or whatever else, because that could change the results and change the reliability and validity of the test. It's not usable anymore. So you test as many folks in a quiet, calm environment, and then you will give the test in the same type of environment to the person you're examining to see how much like the, quote, neurotypical, quote, person, that in order to see whether their performance differs. And if it does, how much their performance differs from the neurotypical. The more it differs, the more likely there is specific damage. And the different subtypes of tests tell you what areas are affected. So if I'm testing an average person off the street and they score like a 7 or a 25 or whatever, and as they get maybe 25 questions right, if I only get 15 right, it's clear that I've got a problem. And I want to reproduce the test results in which I only got the 15 right as close as accurate to the ones in which I tested all those normal people. That's why it's in a quiet and calm environment, is to prevent distracting and confusing factors. So that is why it's not done in a loud environment, something that replicates your office or your factory or outside or where you work. Because what's normal for you is not normal for the other person, and it needs to be as neutral as possible so the results are valid and reliable. And so what is said about you can be said about others who take the test too. It is for statistical reasons and control. And so clinical neuropsychology is a discipline of looking for brain injury, brain lesions through the application of mathematical and statistical techniques and using tests, which are based on comparisons against the so-called normal population, average folks, some above average of all different ages, and a comparison. So it is a statistical comparison, you versus other people. And the cognitive neuropsychology is looking at this average population. Cognitive neuropsychologists look at how a normal person or average person performs and things they can and cannot do, and then uses this data to build a profile for those with disabilities, head injuries, strokes, anoxic injury, heart attacks, all this different stuff, and helps to see that way. Because CTs and MRIs just don't show the subtle effects that brain damage can cause. And so that is a quick synopsis of neuropsychology and neuropsychological testing. Thank you.